After that, there will be another live case from National Cardiology Hospital. So if Mariano is ready, let's go.
Start. Hello. Can you hear me?
Yes, we can hear you. I'm sure there is no such thing like impossible revascularization in your hands, but show us.
Yeah, the title changed a bit. First of all, thanks for anticipating my presentation because I need to run take my flight, and we are talking about break all the boundaries in impossible revascularization and what we call the Reconnect technique. So you can see in my introduction any place where I'm collaborating today, and two of them are in Bulgaria. No conflict of interest with this presentation, and a very fast introduction. When we talk about FEMPOP revascularization in general, we must to also think about open surgical revascularization. Personally, and many papers show that that is still a gold standard for specific indications like thromboendarterectomy of the common femoral or some pretty well indicated cases for bypass, and most of them venous bypasses. There are many guidelines and also consensus, local consensus that suggest to avoid to limit options. It means at the beginning when endovascular approach was growing fast, all vascular surgeons and endovascular specialists, we start all to discuss about to don't limit the options. So don't put the stem in a place in which I could do a distal anastomosis, completely different compared to the case we really did. But the same should be in the opposite sense. I mean, don't close the endo options when you do surgery. For example, no surgical ligations, no disconnections, or other surgical strategies that could close the ways to go in endovascular approach. For example, thromboendarterectomy plus profundoplasty, iliaco-profunda bypasses, or terminal anastomosis. This should be avoided. But let me show a couple of cases and describe this, what we call the Reconnect technique that honestly was born and developed here in Bulgaria. This is a case of 59 years old male with CLTI of the left foot, Rutherford 5 peripheral arterial disease. He did a FEMPOP bypass 6 years ago, interposition between common femoral and profunda with a graft, plus 2 PTA on the bypass, plus stent implantation, plus many things. You can see the comorbidities of the patient, and at the end, the patient arrived in this situation. Look, we did a very difficult crossover, and the first check show us the bypass between iliac and profunda arteries, and no any other vessel. But I will try to fix a bit more. You can see here there is a stent that went inside previous bypass, completely crushed and destroyed. So no finding any other way to enter. We did a retrograde access in the anterior tibia. We were in the lumen, and we were easily able to navigate and to cross all the popliteal artery and all the SFA that you can see heavily calcified. So completely different compared to the case we show now. This case was much more challenged, and look, one anastomosis terminal, one stent, another crash stent. So from endovascular perspective, impossible to connect the native artery with something. We were trying even with the back tip of pterumostiff, but it was impossible to pass. So what we did, we are so creative. So we opened one snare inside the bypass, iliaco profundo bypass, second snare in the distal SFA, and with more than creativity, we were able, after more than 30 minutes of trying and broken needles and doing things, we were able to puncture the first snare, and in a very complex situation, we were able to also puncture the second snare We needed to change the projection multiple times to realize how were those, but at the end we succeed. We put an 014 guide wire through the needle. We retrieve the proximal tip of the guide wire with the first snare. We retrieve the back tip of the guide wire with the second snare, and we reconnect the disconnected. We dilate with a 5 mm balloon, still residual stenosis because the bypass is in a prosthesis. We dilate all the SFA and all the popliteal artery at 5 and at 6 mm. You can see how difficult it was to open properly this place of connection. We had a small fistula also. We passed to 6 balloon. We passed also to 7 mm balloon, and to also fix this fistula, and this is the only one case with cover stent, we decided to deploy a 7 mm eye cover stent that guarantee no more fistula and excellent inflow in the native artery. Afterwards, in a presto technique fashion, we deployed two superior stents, 5.5 200 and 5.5 150, to cover all the SFA and to cover all the popliteal segment. So trying to go from healthy to healthy as much as possible. You can see the amount of calcium in the distal SFA as well as in the POP segment that were previously fully occluded, and you can see how we managed to finally stent it and to cover all the calcified lesions previous occluded that we were able to manage. Afterwards, we went with a 3 mm balloon to the hemostasis, and this was the result. Excellent flow in the SFA and POP, direct flow for anterior, and direct flow from anterior to the dorsal circulation with collateral feeding also posterior and peroneal. But yeah, this was not the only one case. We have more than 10 cases between Sofia, Plovdiv, Burgas, and Abanoterme. And it is also useful to connect the disconnected distally. This is a second case, 60 years old male with intermittent claudication and CLTI, Rutherford 4, so rest pain, limb ischemia, previous fem pop bypass. This was the distal SFA to TP trunk, terminal anastomosis, plus many other things that at the end arrived to us with occluded bypass, occluded popliteal artery, good anterior tibial, good peroneal, and very poor flow in the foot. So we engaged with Oscar, and you can see the clips. We were completely unable to advance antegrade. So again, retrograding anterior tibia, and the luminal crossing of the proximal of the distal popliteal artery, and finally we engaged the POP. We were able to go up and look again, not so close one to the other, quite distant. We start to force, we start to be more aggressive with the back tip of 018 guide wires, trying to do like a Riente device system, but it was quite impossible to connect these two areas, even if it seems to were closed. So at the end, again, double snare strategy at the knee joint. We check that the snares were both engaged. We pass again an 014 wire. We retrieve the proximal tip of the wire with the first snare. You can see very easily, relatively easy and fast to do. We retrieve the second tip with the second snare. And again, 5 mm, 6 mm, so difficult to open it. So we decided even to go with the cutting balloon, 6 and 5. Afterwards, we passed the cutting. We were able to open it with a 6 mm balloon, high pressure, and we went again with superior stent to fix this heavily angulated, really angulated anastomosis or new tract with excellent result. After this, again antegrade, recanalization of anterior tibial and dorsalis pedis. We were able to manage in the meanwhile the retrograde access with the balloon angioplasty, and we did the foot recanalization with dilatation at 2.53 and proximal anterior tibial 4 millimeters to manage this complete recanalization of dorsal circulation. You can see that we were even able to go around the foot like we did during the live case. We dilate even retrogradely the lateral plantar, fix the dorsal circulation, and this was the result. Excellent flow in the fem pop, direct flow for anterior tibial through the anterior tibial into the dorsal circulation with excellent perfusion for the forefoot and reverse flow in the lateral plantar. So data and literature, just to discuss a bit deep. It's really new because only sutured SFA cases already published exist, but treated by endovascular approach with re-enter devices. What means a relatively close anastomosis or disconnection. So completely different to our experience, and no references about iliaco profunda or terminal anastomosis. We actually have 13 cases performing between Italy and Bulgaria, as I mentioned, Sofia, Plovdiv, Burgas, and Abanoterme. 100% of success rate with 0% of complications, high rate of stenting, because in most of the cases we deploy stent to manage these reconnections, but in only one case we need cover stent, the case that I show you. All the other cases remain without cover stent. And we also did in Burgas one very distal, I reconnect posterior tibial artery to a femoral peroneal bypass. So the bypass exclude completely the arteries from the circulation, and with this reconnect strategy, I reconnect posterior tibial to the bypass, again with a small stent but not cover stent. How is the view of our strategies? Well, this is the view, and very angulated 90 degrees supera stent from the SFA into the common femoral after the reconnect strategy. That's the reason why most of the cases we use supera, a mimetic technology to avoid any stent fractures. So in conclusion, surgical revascularization should never reduce other options for revascularization. This should be mandatory. Aggressive endovascular approach cannot fight with disconnected arterial segment. So even if we use the re-entry devices, when you really disconnect the segment, we cannot fight with this. But the reconnect strategy can be of support to connect the disconnected, always thinking about clinical indications. So all our cases were with CLI patients, no full claudications. And yeah, it was inspired by Dr. Marta Lobato and Agustisa double snare off-the-shelf technique for the DVA creation. Thank you so much for your attention.
Thank you very much. Nice presentation. You killed the hybrid approach. The next... It's very difficult. It's look very difficult and very dangerous without cover stent. How you do you call the vascular surgeons after these procedures?
Yeah, I called the vascular surgeon who did this procedure to ask them to stop.
Bravo, bravo. Amazing presentation. Have a good flight. Thank you from the audience here, and we will see you in Burgas.
Thank you.
Bye.
Bye.